East and in the world about his interest of non-invasive ventilation. He's the editor-in-chief of the Journal of Perinatal and Neonatal Medicine. He had several publications, and it's our pleasure to have Prof. Hani today to talk to us about non-invasive ventilation in preterm infant. Prof. Hani.
Well, thank you, Dr. Jabara, for the introduction, and thank you for the invitation to join the first conference in neonatology in Chad. We are having 30 minutes, but my slides were for more than 30 minutes, so I'm going to skip some slides, so I hope that will be okay with you. And I think we'll be fine because Dr. Sol has covered some of the slides that I was planning to give, so that will make it fine. So when I'm talking about a non-invasive ventilation for prevention of BBD, bringing it on based on my experience, this is trying to see how to make the pointer. So, out of fellowship at Columbia University, I started the program with Bcpap at George Washington University, and you see the use of CPAP has increased significantly, and that was associated with decreased incidence of chronic lung disease, defined as oxygen use at 36 weeks, from around 40% down to 5 to 6% within 3 years. And just published in 2020, my conclusion of 16 years after establishing low BBD to see if that will continue or just was a fluke for a couple of years. So over 16 years of experience, you can see the BBD was 7.6%, came to 7.5, 5.8. These are each 4 years period. So basically I left Washington, DC with a solid 5% instance of BBD, defined an oxygen use of 36 weeks of gestation. But then after I went to Cleveland Clinic, and that is the instance, I remember right before I go to Cleveland, I was in Riyadh giving the workshop on Bcpap, and so this is my 5 years at Cleveland Clinic, again, 40% BBD, and now we are enjoying the single-digit instance of BBD. I see here there are CPAP 1 and CPAP 2 because we do have 2 labor rooms, 2 delivery rooms, 2 hospitals, 11,000 deliveries. So I had to start 1 unit at a time, and then after that, go to the other unit. So my objectives is to define or identify the mechanisms of ventilator associated lung injury and recognize the variation of instance of chronic lung disease among centers. It can't be lung disease that is causing BBD. Can't be. If you have one center with 5% BBD and the other with 50% and say that this is because of premature lung, it doesn't make sense. The variation could be from 1 to 2%, but not 10-fold increase in instance of BBD. It has to be the management. So I would like to go over the concepts and the skill. Of course, babies, we are supporting them either with invasive or non-invasive. When you look to this type of X-ray, very similar to the one Dr. Sol just presented, that kind of severe BBD was, you cannot see border of the heart from macroatelectasis and fibrosis and no diaphragm seen. You cannot have this type of X-ray without an endotracheal tube. You cannot have a severe BPD in a baby who never been intubated. That is so simple. And these trials, Dr. Saul again just defined, it was a quiz, which of these therapies are shown evidence-based to decrease chronic lung disease? So the answer is none. So really you have an equation. Baby has an RDS, then we intubate the baby, then chronic lung disease occurs. And all our therapies that are towards prevention or treatment for RDS was like prenatal steroids or giving antioxidants, though the ET tube is the major problem that we have in the equation. And around the same time in the 1980s, 1987, Dr. Kolobov at NIH has done an animal study, adult animals, electively intubated and ventilated with pressure, either pressure of 20 or pressure of 50, without adding CO2 or with adding CO2. And looking to the outcomes of these adult sheep. The outcome actually was not a lung outcome. It ended to become a death and alive outcome. All animals in group A that were ventilated with a pressure of 20 or less than 20 survived, except for one animal. And then all animals in the second group, they all died at the median age of 23 hours. You didn't need more than 1 day to kill a life with the wrong ventilator setting. That's how dangerous ventilation is. And then in the third group that have CO2 added to the circuit, 6 out of the 9 died in 36 hours, 1.5 days. And then when looking at the lung volumes, you can see the light blue, that is using pressure of 20, and then regional pressure of 50 is dark blue and yellow after adding CO2. And these were the same animals. And after just 1 day of ventilation, lung volumes become 50% decreased. FRC, compliance, and tidal volume, they all have been compromised. And histology, you can see with a pressure of 50, you can have severe lung disease. And then this another study, animal study, was done in Sweden multiple years ago. How about intubating the preterm lamb and giving the preterm lamb just 6 bagging, but use a little bit of a big volume. You give a bag to the lamb with the extra volume beyond the tidal volume. And let's see what happened. So when you look to the control lamb that did not get the bagging, this is the pressure and this is the volume. So the pressure volume curve, this is the compliance. Before surfactant, I just have hard time with the pointer. So before giving surfactant, you can see the compliance was down to less than 10, around 5, the volume. Then after surfactant, you can see the volume of the lung has increased to 30. But with the animals that receives just 6 aggressive bagging, lung volume is completely compromised. After surfactant, didn't matter. 10 cc's of volume, here is 30 cc's of volume. So you cut down the lung function by 2/3 just by giving 6 bags in the delivery room. And just imagine when we are intubating, giving surfactant, then you bag, and then you already killed the lung before we even will start to manage the baby. And here is the histology. You can see the much significant difference in the control versus the aggressively bagged with the alveolization. You can see the alveolization down there is much better than up there, the space. This is a case of CDH. We all intubate diaphragmatic hernia so that the lung, the intestine doesn't expand into the lung, but the baby desaturated, and immediate bedside nurse will disconnect and back. In no time, you can see the tamponading of the heart, pneumopericardium, the pneumothorax, pneumomediastinum, pneumoperitoneum, and the patient died. This is a baby I was attending, and called from a small hospital. They don't have a NICU, and they have a baby under oxygen hood, 32-weeker under oxygen hood. So we went to pick the baby. So the trainee who went to pick the baby, they said, quote unquote, for safe trip, let's intubate. So they intubated the baby, backed the baby for 20 minutes. The baby arrived. He's already in 100% oxygen, severe PIE, flat diaphragm, and the baby on the same day of arrival died. So really the concept that we'd like to focus on is the neonatal lung is a very delicate organ. The intervention, even for a brief period, can cause serious lung damage. And the adverse outcomes that we see are mostly related to our management rather than to the disease itself. Therefore, the least intervention will achieve the best outcome. That is really the concept that we are working with. This is my 16 years of experience, just FYI. Babies, that's all babies less than 1,500 grams. And this is the gestational age around 27 weeks, 997 grams. And here is 1,000 stratified by birth weight categories. Babies 1,000 grams to 1,500 grams, incubated median time, 1 day. 750 to 999, 2 days. 500 to 750, 7 days. And for a reason, because these babies have high risk for IVH. So if the baby got intubated, I don't want to extubate in the first 3 or 4 days of life, because if I extubate and he failed, the trial of intubation itself can introduce another IVH. So basically, the vast majority of our babies who are intubated 1 to 2 days at the most, then you don't have any BBD in this group. Now I have BBD only in this group 3 and 4, less than 750. That's how I brought the BBD down. I don't think I'm able to bring BBD down that significant in a baby who's 400 grams or who's intubated. Once the baby is intubated, I don't see any difference between my unit and any other units. So the skill is how to keep the baby not intubated. So now the non-invasive ventilation, it can be, there are so many options. And many times people say, oh, he's not intubated, he was in CPAP. What type of CPAP? Is it a ventilator CPAP, or is it a bubble CPAP, or is it a ram cannula? So are they different? So of course they are different. And you see the hipster trial for early use of high flow nasal cannula for babies who are greater than or equal to 28 weeks. And you can see the high flow nasal cannula compared to CPAP. That's all type of CPAP, not the bubble CPAP. You can see the failure rate and for needed to intubate on the high flow nasal cannula is double, that is 25.5 versus 13.3. And then the Hunter trial, repeat the trial again, but now with a 31 weeker or higher. And you can see the failure rate is 20.5 and 10.2, double the rate. So you double the rate for need to intubation if you are using high flow nasal cannula and not CPAP. And again, CPAP here is any type of CPAP. So when used as a primary support for preterm infants with respiratory distress, this is the conclusion of the authors. High flow therapy resulted in a significantly higher rate of treatment failure than did CPAP. So I think if we're going to come out with one take-home message from my lecture, is there is no evidence to support the most popular therapy that you have done in the NICU, which is the nasal cannula. Nothing to say that baby will get improved if we give him nasal cannula. So when you talk about the evidence-based medicine, there's a process and there's a content. And I just don't want us to get trapped in the methodology and forget the content. It has to make sense in order for us to really agree on it. I'll just give you one example, and this is a randomized control trials on the use of CPAP versus mechanical ventilation, for example. And you can see for the support trial for 24 to 27 week, BBD is 40% on CPAP. On the COIN trial earlier for 25 to 28 week, BBD is 29%. Then Steve Dunn trial in Michigan, 26 to 29 week, BBD is 26%. And these are all non-significant. So really, CPAP did not decrease the incidence of BBD. But when they were all added together, meta-analysis, BBD is still not significant. But now if you add this or BBD, you see the relative risk is 0.91. So if you use CPAP on 100 baby, you will have the chance to decrease BBD or death in 9 baby out of 100. But that does not conceal with the slide I showed you at the start with a 5% instance of BBD and 6% instance of BBD. And this is not a historical, they are living example. If you go to Columbia University, to Cleveland Clinic, to George Washington University, they are existing example that's there. And this is Mary Avery, Dr. Saul, he alluded to her study. Of course, Dr. Avery was the one noticed and wrote on the experience when she saw that premature babies, when they have bubble in their mouth, they tend to survive. When they don't have bubble in their mouth, they tend to die. And that was the start of discovery for surfactant therapy at that time. So she reported 8 different universities in United States and 1 center from Canada and Toronto, Mount Sinai, and Columbia has the lowest instance of BBD, and that was referred to Dr. Jin Wang, and he was using only bubble CPAP. No variation, no different types of CPAP, and using only this type of bronch, the Hudson bronch. And how CPAP would work, and of course, for the sake of time, I will not elaborate, but I just would like to let you know that surfactant, that CPAP stimulates the lung to grow. You keep a baby with CPAP, that's a therapy. Stimulate the lung will get bigger. And that's how you can decrease BBD. Can you please remind me in 5 minutes? So there was a study from Rochester on ferrets, having ferrets with tracheostomy with or without CPAP valve on their neck. And they found that at baseline, the total lung capacity was the same in the 2 groups. After 1 week, there was tendency, but that was not significant. But it took still 2 weeks on the CPAP valve to show that the lung has grown significantly. Needs time. And it's not just the overstretching of the lung, it's not just the volume, it's the volume, the weight, the protein, the DNA. There is actual growth of cells in the lungs with CPAP. And I have shown in a randomized control trial, when I switch a baby from CPAP to nasal cannula, so babies, premature babies who are still on CPAP requiring less than 30% oxygen, if you divide them into two groups, randomly assigned to switch to nasal cannula or to continue with CPAP, no nasal cannula, the duration of oxygen therapy significantly decreased, and the duration of all respiratory support significantly decreased. So we keep babies on CPAP until they don't require any other support. Most recently, just a study just came in JPEDS. That's for babies now, bigger babies who are 32 weeks or less, who were in CPAP for at least 24 hours. And then these babies, once they finish CPAP for 24 hours, they were randomly assigned to two groups. One group continue on CPAP that they didn't need it, but they continue on CPAP. And the other, they just stop CPAP to room air. After 2 weeks of CPAP therapy, the FRC, the functional residual capacity of the lung done by nitrogen displacement test, significantly decreased. And here at 2 weeks, they stopped the CPAP on the treatment group. But then at the time of discharge, they found even the lung capacity has even increased more. So keep the babies on CPAP to stimulate the lung to grow and to eliminate the oxygen need. Look at this slide again for the 16 years of experience. There is no time in any baby that you have the CPAP days versus oxygen days. So it's always oxygen days 4 days, CPAP 17 days. So the baby was on CPAP with oxygen for only 4 days, but then continued for another 12 days on CPAP, 21% oxygen. And every time we tried to take him off CPAP, he showed descent, I put him back. 17 days of oxygen and 45 days of CPAP. And for the less than 500 gram, 51 days of oxygen, 77 days on CPAP. But when you look to many of the trials or many of the studies published, you find that the CPAP days is 2 weeks, oxygen days is 2 months. So the baby did. I just want to visit with you, does intubation cause IVH? So back in 2000, of course, there is no randomized control trial to look at this specifically in the high risk group. There is a trial on the generalized group that are bigger babies who may not have IVH anyway. But after in a 342 baby, when I looked at the instance of IVH in a regression analysis, I could see definitely odds ratio to get IVH in intubated babies 2.7. Almost 3-fold increase in risk for IVH when you intubate a baby after controlling for birth weight, gestational age, sex, and race, and other factors. But then this study just came in JPEDS 2016. Now we're talking about babies who are all intubated. But intubated first trial versus second trial versus third trial. And you can see in the study by Neil Feiner and group, each additional trial of intubation is associated with 1.317 odds ratio. You have a 30% increased risk for IVH with each trial. So that's why I do not advise to try trainees. They are not going to try in the delivery room to intubate babies. Let them try after 1 week in the NICU or in bigger baby, but not in a 500 grammer. This baby is going to be handicapped. And for babies less than 750, the same thing. Severe IVH was
5 minutes then.
Okay. Severe IVH was associated with each 1.395, 40% increased risk for IVH. So should I give insure to my babies? So the answer, I will not give insure to my babies because I know that IVH is a problem. So this is just CPAP failure. You start a baby on CPAP, how many of them will require intubation? It really improves with experience. So over 3 years, when we started the CPAP, 39% failure rate and down to 5.6% failure rate. And these are all nursing care at the bedside. So how can we succeed with the use of CPAP to really reproduce this type of experience? We always have a setup ready in the NICU. So it's too late to get the baby delivered, then ask our RT to bring CPAP. CPAP has to be ready. If even you can apply it in the delivery room, it will be even better. If you don't have bubble CPAP in the delivery room, you can use the new puff or TPs to give CPAP, rush the baby to the NICU to be in bubble CPAP in the first minute of life. Meticulous attention to airway every 3 hours to get the secretion out in order to prevent And I like this quote from Bruce Lee for martial art. He's saying, I'm not afraid of a person who knows 10,000 kicks, but I'm afraid of a person who knows 1 kick, but he practiced it 10,000 times. So really having one unified therapy and train your nurses, RTs, physician, everyone on it, on and on and on, become perfect, then the failure rate will come down. And always you'll find people would like to go from you push them from the comfort zone of the nasal cannula and ventilator. They're afraid because they don't know how to use CPAP. Then you push them to the learning zone, then that's how to grow. But every time you find a tendency, people wants to go back to the comfort zone. So I just need to stick to guidelines, do not go backward. And that's why we are doing training on a yearly conferences on hands-on training for the CPAP. There is a detailed checklist that the nurse at the bedside will go over 20 different points and make sure that they are all using the exact way for the exact CPAP, and there is no time to go over the details. And also we have a process reliability measure to confirm that what percent when we do audit, what percent of our babies are 100% compliant with the checklist. So in conclusion, no evidence to support efficacy of high flow nasal cannula in preventing BPD. NICUs with the lowest instance of BPD, they use exclusively bubble CPAP, no other form of CPAP. The strategies that improve outcomes should be favored over strategies that are more comfortable to our staff and easier to care. Thank you.
Thank you so much, Prof. Hani, for this nice, interesting presentation. Please, can we have the speakers for the questions now? Can we come here and start? My colleague, Dr. Jubara, she will run the questions.